Hi, good morning. My name is Dr. Rajat Nan Ahmed, and I'm a psychiatrist working in UK. And this morning I got Dr. Asadullah Anis Khan with me. And the purpose of doing this interview is to guide the next generation of IMGs about oncology and how to go about getting the training into it and some basic tips around it. So I'll say something about Asad. Asad came to UK in 2017. He's a graduate from Pakistan, from Lahore since 2015, and he came via the PLAB route. And then he completed his CMT training here and also the MRCP. Then now he's going to start his Clinical Oncology ST training, which will be for 5 years. And he got that recently. And he, as I've as we understand that he scored really good on his interview scores. I think that is something which will be useful for IMG, especially if you are looking into go into clinical oncology, to get some tips from him. The other thing Asad has done is actually open up a lot of social media platform where him and some of his friends are also sort of trying to help the next generation of IMGs in understanding some of the basic specialties, oncology and some hematology as well. So I'll share some links on of his clinical of his social media platform with this video as well. So Asad, thank you very much for joining me and taking time out from your busy schedule.
It's a pleasure. Thank you very much for having me.
Can you tell us a little bit about your journey into UK? So, I mean, in introduction I said some things, but would you like to elaborate a bit more and how did you come so far?
Of course, I graduated in 2015 from Lahore, Pakistan, and did my PLAB during my house job in 2016. PLAB 1, PLAB 2, and then after my house job in 2017, I started working as a surgical SHO in the UK. It was I took up a surgical job because that's what I originally wanted to do. But obviously, having worked in the system for about a year or so, I realized that I didn't enjoy it as much as I thought I did. And then I changed my path towards medicine. So I changed my job to a medical job, applied for co-medical training, and got into co-medical training. And I started that in August 2018. In 2 years, I completed all parts of the MRCP, and was working when the first wave of the COVID-19 pandemic hit. I was working as a medical registrar during my CMT, having completed my exams. After my CMT, I worked as a registrar in a dual job as a general medicine slash oncology registrar. And then after that, I applied for ST training, and then I obviously got it.
That's great. One of the common questions you are already getting is about the difference between clinical oncology and medical oncology, and how do you differentiate between these two? If you can clarify
Um,
that for the IMGs.
Yeah, of course, yes, I will. I think the basic difference is that clinical oncology is a specialty that deals with the science and the delivery of radiotherapy. The UK is quite rare in that aspect compared to the rest of the Western world. If you look at America, these doctors are called radiation oncologists, similar in Australia and similar in New Zealand, Canada. The UK is the only country in the Western world which still trains clinical oncologists to deliver radiotherapy as well as chemotherapy and other systemic therapies. So that's quite nice in a way. Um, you get trained in all aspects of the science. So that's the first difference. Medical oncologists do not deliver radiotherapy. If they need a patient, if they need to deliver radiotherapy to a patient, they will refer the patient on to a clinical oncologist. That's the first difference. Second difference is that they are governed by different Royal Colleges. So the medical oncologists are still under the Royal College of Physicians. And quite luckily, they do not have to do any more exams apart from the SCE, which is the specialty certificate in the specialty after they've entered into ST training. In comparison, clinical oncologists still have to do a lot of exams, and that's partly because they are being trained in a completely new um, specialty in terms of radiotherapy, which obviously their colleagues aren't. Um, these exams, I've gone into detail in my blog about these exams, but basically, to keep it very short, there's 4 papers, and then there's obviously an OSCE type examination.
So the next question would be about the recruitment process in clinical oncology. How did you find that? And, is there any difference between a pre-COVID era and post-COVID? Was there any differences? And how was the process of recruitment into?
There was a big difference between recruitment during COVID and before COVID. In fact, I think I was one of the candidates who was adversely affected by that towards the end of my core medical training. The recruitment is as advertised on the ST3 website. It takes you to a link onto the Royal College of Radiologists website. That's where the actual information is for clinical oncology, because obviously it's under that Royal College. The rounds are the same as the higher specialty training in medicine. In terms of grouping, clinical oncology is actually grouped as a group 2 specialty. So you do not need to do IMT3 if you're applying for clinical oncology. Similarly, you do not need to do IMT3 if you're applying for hematology or medical oncology, because you won't be working as a medical registrar, you won't be doing the GIM on calls, and you will not have a dual CCT. Once you apply via Oriel in the standard rounds in November, I think, there's interviews in April, and then you find out in May before you start in either August or September, depending on the intake.
So how are they ranking your application when you're applying for clinical oncology?
So there's two parts of the ranking. So actually, that reminds me, we were talking about how COVID has impacted this. So there's two parts. The first part is actually the self-assessment. The self-assessment is a breakdown of your achievements. So, for example, publications, undergraduate degrees, postgraduate degrees, MRCP does not count. Audits, whether they're related to oncology or not, and if you can demonstrate a proper impact because of your work. Poster presentations, and then there's leadership and management and that sort of thing. All of these things can be done very easily when you're preparing your application. So it just takes a lot of work to actually plan it, which is the most important thing. And just going back to what we were talking about earlier about how COVID impacted this. So when last year, when interviews were about to be held, I remember I was about to book my ticket to Central London to go for my interview, and there was an announcement that the Prime Minister had cancelled all meetings and stuff like that. So my interview was cancelled the night before I was due to go for it, which meant that unfortunately all candidates were ranked on their self-assessment score. They weren't ranked on interview at all. And I ranked 114th nationally because obviously there were a few deficiencies, and I underscored myself because I was scared of overscoring myself that year. In the year that followed, I worked on my portfolio, I made a better application, and then obviously I had an interview, which was the most important thing, and that allowed me to get into training.
And the interview itself, was there just one station or was it multiple stations there? Because a lot of specialties are doing like multiple stations, including clinical scenarios and all that.
The interview is divided into a couple of, I think, 4 sections. Clinical oncology is different from medical in the sense that it's got more clinical scenarios. So medical oncology interviews have more research-based and academic scenarios. And the reason for that is because almost all medical oncologists inevitably end up doing a PhD. Most clinical oncologists still end up doing a PhD, but it's not as hard a requirement as it is for medical oncology because they have to focus on drug development. So the division is that there's 2 clinical stations, scenarios, and obviously this is like a viva interaction, I think roughly about 6 minutes each. And then you get a STEM, and then followed by specific questions that the examiner will offer. After that, there's an ethical scenario, which is, again, as you mentioned, quite standard in all medical interviews. And then after that, there's quite a long 12-minute station where you actually get to go through a portfolio, which can actually work in your favor. I think that would be the best station if you wanted to.
Okay. And if some IMGs, junior IMGs, are looking at clinical or medical oncology, maybe they are still in their home countries or they are doing some core medical or IMT training right now, what should they be doing to improve their CV in a way that will help them in this interview and recruitment process?
Um, I think one of the most important things that I realize now is, the one thing that I potentially could have done when I was back home is probably work on the other parts of your CV apart from passing all the exams. The publications and the presentations. I think this is the one part that I didn't really work on as much as I should have. So that's one thing that I think they can do. In terms of other things, I think one of the things that unfortunately as IMGs we frequently end up doing is that we try to plan ahead for our specialty, but we forget that we have to go through, getting a job, GMC registration, core medical training. We have to go through the basic steps before we get to that point, and that is a very long path, and it's actually very hard. So I think I would focus on sustainable, achievable goals, and I think that would be the publications and presentations. Apart from that, everything else can happen once you're here.
Okay, and do you have to show any specific when you are going for interview or recruitment process? You have to show that you are actually interested in clinical oncology. Is there any evidence that they sort of ask for that you have done something specifically in oncology to in the interview or the pre-interview ranking?
Yes, absolutely. So sorry, this relates to your previous question as well. One of the things that they could do is obviously have evidence of working in oncology for a long period of time. I only had 2 weeks because of the way my house job was structured. Obviously, that was out of my hands. So in terms of planning your portfolio to show commitment to specialty, which is the most important part, as I said, those 12 minutes are crucial. What you can do is you can try your best to make sure you work in oncology. So you can try and land a job in oncology if that's possible. It's different depending on how busy the system is and applications and stuff. So working as a trust grade in oncology, that's the first thing. Second thing is making sure that your internal medical training has an oncology rotation, even though they've included intensive care and geriatric medicine as compulsory rotations now. There are still definitely centers which do oncology rotations in IMT. This is very important. I didn't have that, which should be a very good sign for people, because if I didn't have that and I still got in it, it's encouraging. I had the next best thing. So I had palliative care, and I used that time to improve my portfolio. The other things that they could do. So some of the other things that they could do to show commitment to specialty, I'll give you some examples of what I did. So during my core medical training, I did a very easy QIP, but I did it over 2 years. So in CT1 and in CT2, it was very easy. I called about 30 patients about the understanding of their lung nodules, which is quite common. And then we introduced a leaflet and sent it to their houses, and I re-audited that next year. I did it only because of my interest in lung cancer, and I was able to demonstrate that I got a certificate from my consultant, as well as proof of the audit. So I was able to demonstrate I was able to claim full marks on the audit section for that. The other thing that could be done is actually getting involved in teaching of undergraduates, medical students, F1s, and actually being lead in some sort of teaching program. So I in my core medical training job, and before that as well, ever since I've been in the UK, I've been heading the undergraduate geriatric medicine curriculum for the students who rotate to, they used to my previous hospital from St. George's. I did that for 3 years, and anything that's been done for more than 6 years gives you a lot of marks on the leadership aspect, as well as giving you full marks on the teaching aspect, because I worked with the college tutor, devised the curriculum, arranged faculty, and also arranged rooms for speakers to speak and all of those things. So I got full marks on teaching, and I got full marks on the QIP, and I got quite a lot of marks on the leadership aspect of things as well. The one other thing that could be done is being a rep. So it's always possible to be a rep in core medical training, or ACCS, whichever pathway you take. That gives you a lot of marks as well. Sorry. Apart from that, what I did was I got an honorary contract with my local tertiary cancer center, and I went there to observe radiotherapy planning, radiotherapy deliverance, and we just work with some of the consultants. Unfortunately, COVID did impact some of those plans, but these are all very, very useful things that are foolproof ways to get full marks.
Okay. There's another question which a lot of IMGs would be interested in. That working as an oncology, if you have trained in UK, working abroad from the UK qualification, countries like Middle East, Australia, New Zealand, and if you have to even have to go back to your home country like India or Pakistan, um, what is your understanding? Is this specialty have does it specially got that uh, you know uh, scope that it can be practiced anywhere?
Thank you. I think the way I look at it, I've obviously not done too much research into this, but the way I look at it, I did think about this when I was selecting a specialty as well. I'm from Lahore. We've got a big cancer center where I live. Most places do. Um, Patients with cancer, especially in my country and the surrounding area, the subcontinent, or even if you look at it, the Middle East, and basically most of the East, there's many improvements in development that could be done to the management of patients with cancer. And if I talk with my specialty about clinical oncology, if you're trained in radiotherapy and chemotherapy, that gives you an edge over maybe someone who's trained in one rather than the other, and it would increase your employability to employers. So I think there's definitely scope to go anywhere. We still don't have a cure for cancer, so I think you're never going to be out of a job.
Okay.
And the way the training program is structured, you get a lot of academic involvement as well in the UK, and which inevitably leads to research and higher degrees. And again, that all improves your chances.
And one more thing I will ask you about. I understand that your wife is also a doctor, and a lot of IMGs who come here, they come as a pair of doctors, and they always have this anxiety that if we get training, we might end up in two different deaneries or two different areas. We might have to live apart. Some people have young families, and that becomes a very big stressor for them as well. Have you got any tips around what could be done to make sure that as a husband and wife you end up in the same place or same deanery?
Um, a couple of things actually. That's obviously I talk about this a lot on the International Medical Graduates Facebook group as well, and the reason for that is because my wife is a GP trainee, and I was a co-medical trainee in Kent, Surrey, and Sussex. So while I was in Surrey, she was in the Wessex Deanery, which is actually geographically quite close on the map. But the extent of these two deaneries, they're very, very large deaneries, and we had to live nearer to her deanery, and then I was commuting to my workplace. It's very difficult. It's very difficult for everyone. We've talked about this before as well, and you've told me your stories. Um, but I think previously, one of the things that was helpful is that there was something called the facilitated placement, which was really helpful to me because that allowed me to come closer to where my wife was. That's not the case anymore. They've scrapped that program,
Mm.
and now I can tell you our personal experience. My wife applied for an interdeanery transfer, and unfortunately was refused 2 years running, and that's happened to a lot of other people as well. So there are some workarounds of the system. There's something called reapplication to continue your training in a different region. So that's one of the things that my wife has successfully done this year after being refused a transfer 2 years running. And it's one of the things that I will try and highlight and probably write a post on this to guide other people, because we know a lot of families are in the same situation.
Mm.
But unfortunately, there's no workarounds. It's very difficult. The one thing I could suggest is trying and applying 1 year apart from your partner. So we
Mm.
applied together in 2018, but one of the things that we could have done is one person could have applied, got a place, and then waited, and then the other person could apply next year to make sure you're not living apart. That's one possible option.
So, Asad, just the last question. Why did you choose oncology? And is that something that you would recommend to others? If somebody asks you what are the advantages of this particular specialty, what would you say to them?
Um, I chose oncology for a couple of reasons. Um, One of the first things that I'd like to say about oncology is a lot of people think about a group 2 specialty and think they can run away from the medreg job. So it's comparatively an easy job. I think that's a very wrong perception. It's not an easy job. As a registrar of oncology, is a very difficult job. You're frequently based in large cancer centers, dealing with a very large number of patients, having your own take, and it's very, very busy and very, very demanding as a registrar. Um, the positives of the specialty are that number one, it's constantly changing. We had the recent ASCO conference. It is actually going on these days, and even now, the pace and the development of new treatments is astounding, and this will continue till obviously we have a cure for cancer. Um, One of the benefits of my specialty is why I find one of the things why I find it very satisfying, and it's also something I actually mentioned at my interview, is because even if you're not able to offer people a cure, you can still offer people, symptom control. So clinical oncologists can offer people radiotherapy for pain control, for control of the nausea, different symptoms. So it's very, very satisfying. And I've actually been asked this question many times by people. Whenever I tell someone I want to do oncology, I think one of the most common things that I was told is that, don't you find that depressing? I
Yeah.
find it very funny when neurologists say that to me, because it's every specialty has their own cases, but actually people forget about how satisfying it is to tell a young person that they've been cured of cancer. So I think it's the satisfaction is a massive, massive point. The one of the last things is the work-life balance is actually really good. So in the UK, as a consultant clinical or medical oncologist, the work-life balance is really good. You work in close liaison with the Macmillan nurses, with the Macmillan team, and with the acute oncology services, as well as multiple MDTs. And the burden of decisions is shared amongst colleagues. And overall, your on-calls are not too bad. They're well spaced out. You have more time for family. So on the whole, I would rate it very highly on the work-life balance scale.
Okay. Thank you very much, Asad, for this useful interview. You've given a lot of useful points, and I'm sure a lot of IMGs will find this very useful. And with this interview, as I said, I will post the links of your blog. I think you're doing a wonderful job of
Thank you.
offering
Thank
to
you very much.
help the next generation. Because I'm sure a lot of IMGs will get benefit from your postings and get better understanding, basically, of oncology and how to go about it.
Just trying to follow your lead.
All right. Thank, thank you again. Thank you.
Thank you very much. Thank you.